Hello, good morning, everyone. So today we are going to do some MCQs. MCQs in the sense this is going to be more of an explanation when you have answered these questions. We are also going to discuss on the same. So that way we are going to have complete knowledge of what we are actually discussing. So here I have put up a small picture of one of the museums. This is the museum that is in Manipal. This is the Anatomy Museum, and it is one of the India's. Actually, in fact, it is the world's largest, anatomy museum. So I would suggest everyone to, visit if you get a chance in life. So this is one of the fine anatomy museums that you can see in Manipal, from where I studied. Okay, so this one is my credentials. I'm Dr. Rohini Wayan and I studied at Kasturba Medical College and it belongs to Manipal Academy of Higher Education. It's a deemed university and here I also have some additional qualifications like the medical transcription degree and hospital administration MBA. This is hospital administration. And I have PhD from Savita University. This is from Chennai. And I am also a IVF and ICSI specialist. So these are some of the things that you can look out for me in my profile. So I have about 10 years of experience teaching in India and abroad, and I also do counseling for the students, PhD students, NEET, PG, FMG. All these are some of my students who do take the counseling. And you can see that there is referral codes. What is this referral code all about? Referral code actually gives you the access to free products like the special classes, quizzes, tests, etc. So these codes are very important. You can use either one of them for your classes. So when you use this code, you will have access to all the free products that the Unacademy offers. And also you will get 10% discount when you go for those plus and iconic subscriptions. So try this 10% discount. So these are some of the dedications that has been done by my students who have put in so many, minutes of hard-earned minutes that they have earned because of watching the classes. And these dedications are from some of the very nice, fine students like Blue Hat they have got, and some of them have got orange, brown, blue, brown, red, etc. And these are given when you achieve certain view time. And these are the dedications, and you can also see the number of followers, and this is how my profile looks like. And you can also see the other credentials. So do visit my profile at Dr. Rohini Wayan. And also this is my username, ROHAQUA. When you visit the username, you will get to see all the other details. So here there is plus subscription. What is subscription? Plus subscription. Here the plus subscription will allow you for daily live classes access, test series, structured courses, and unlimited access to various things. So this is plus subscription. So that is little different from the iconic subscription in the sense that iconic has the access to both the prep ladder as well as the Unacademy. So this one has the access to Unacademy. So there is a slight difference in both of them. And this is the iconic, what I was mentioning. You can see that there is a Unacademy as well as prep ladder listed here. There is live classes, video lectures, and you can also see lot of test series, revisions, etc. Unlimited time offer. Unlimited time offer is on 36 months, 24 months, 18 and 12 months. So all these have got price slashed. About 10% discount you can see. 92,000 has been reduced to 58,500. Similarly, 77 to 49,500 and so on. So all this 10% discount you can see in the limited time offer. So first 500 students are going to be the lucky ones. Next, you have INI-CET NEET PG 2021, where you have 3+1 offer, where the 3 months plus 1 month completely free you can get, and 12 plus 2 also you can see, where 2 months is added to the 12 months, and altogether you will get 14 months of subscription. So this is also available within 30 days you get this. Okay, you also have this new thing, 4-year subscription. 4-year subscription is very interesting because this is for those who are doing UG and want to have a firm foundation towards their NEET PG. So when you do that 4-year subscription, you have a lot of advantage in terms of, the fees as well, because it is just 60,000 if you work it out. 60,000 for 4 years is really, something that anyone can afford. So this is plus subscription, and you also have iconic subscription for 75. So there is another feature, raise a hand. You must have seen this in plus classes where you can interact with the educator, and there is also EMI option where you have 48 months for 1125 and 48 months 1406. So this is again depends on which one you take, either iconic or plus. You have a EMI option, and minimum 6 months of subscription is what we look at, and you have to use the code. So you can use my code, name itself is the code. So see the name ROHINI, that's your code. And let's move on to the first question. What do you see here? Hi, Dhriti. Good morning. Okay, so now here we have identify. There is a picture which shows some swelling in the neck. What is it? Any idea? What is this? Swelling. You can see the swelling. What do you think this is because of? So what structure could be present in this region? So it is not in the exactly in the parotid region. It is below that. It is in the neck actually. So you should be able to differentiate between the tonsil, peritonsillar abscess, and parotid abscess. Okay, so that is not around the ear. It is below in the neck. So it is peritonsillar abscess. So what is peritonsillar abscess? What do you know about peritonsillar abscess? It is one of the complications of the tonsil and tonsillitis, and its development means that the infection. So now whenever there is an infection only, you can have the peritonsillar abscess. Otherwise, no. So this is peritonsillar abscess. So it could also be because of untreated strep throat. So I'll just write it, untreated strep throat. Or it could be because of the tonsillitis. That's another reason. And it could also be because of mononucleosis, and that can also cause peritonsillar abscess. And what could be the other reason? Any ideas what could be the other reason? So it could also be because of the tooth infections and gum infections and The only, reason without any infection and completely something else that could lead to peritonsillar abscess would be inflammation of the glands. Which gland do you think? There are small salivary glands called the Weber's glands. Underside of the tongue, you can see these Weber's glands, and inflammation of these glands can also cause peritonsillar abscess. So it need not be all the time tooth and gum and the oral cavity and the strep throat. There could be the inflammation of Weber's gland. This is something that usually people miss out. And since there is nothing of this listed, they will think that it need not be peritonsillar abscess. It could be something else. But they should also look at the inflammation of the Weber's gland. Okay. So the spread of infection. Now, whenever there is inflammation, the tonsil will obviously swell with the pus. Whenever it breaks up and the pus spills around the space, and that can cause the inflammation on the surrounding structures, and that is known as peritonsillar abscess. And you can see that the part on the neck side is swollen. Okay, so now here, how it passes, it is usually from the peritonsillar abscess through the superior constrictor muscle, okay, of the pharynx, and then it results also sometimes in the cellulitis of the neck, and that can also, go into parapharyngeal space in the neck. All right, the second one. So good morning, Sai. Good morning, Santosh. Good morning to each and everyone who is watching this. Next, identify what is this. Now, this is around the neck. This is around the ear region. Now, you can see it is not in the neck. They have not shown the neck. It is the ear, around the ear, in front of the ear. So what do you think this is, Santosh? Any idea? What do you think this is? This is the swelling, parotid swelling. So parotid swelling. How do you think the parotid swelling could happen? See, now you know that the parotid gland, it has got two coverings. One is the outer covering, another one is the inner covering. So I would just call them as the superficial and the deep. Superficial and the deep. So this is nothing but the deep fascia covering the parotid gland. Now what happens in the superficial is it is attached to the zygomatic arch. So zygomatic arch is holding this superficial layer and it is enclosing the parotid gland from the outer surface. So this, whenever there is an infection of the parotid gland with mumps infection, viral infection, it can swell, and then the superficial fascia, since it does not stretch, it can lead to a lot of pain as well. So that is unyielding nature of the superficial layer of the parotid fascia is what results in a lot of pain in the parotid swellings. Now you can see that parotid is a gland which is derived from the ectodermal origin. So it can also result in abscess. So parotid fascia is adherent to the gland and attached above to the zygomatic arch. This is also one of the reason for the collection of the fluid within the gland, and that can result in an abscess. So now the deeper layer which is present on the back side or the inner side of the parotid gland, it is attached to bony structures. You can see the tympanic plate from the temporal bone and the styloid process and also squamotympanic fissure. All these things are the ones which give attachment to deeper layer of the parotid fascia. Okay, so it is like a soap box. Outside there is one layer and inside there is one layer. Outside is attached very firmly. That's why it won't stretch. Okay, so out of the two layers, which one is more important clinically? I would say the superficial layer. Okay, next one. Which fascia is this? Now, there is gland that you can see. It is enclosed in the fascia, and you can also see that there is the cartilages of the in the neck, the midline structures these are. So I'm giving you hint. So think, what are these midline structures? Look at them carefully. You can also see the inlet of the larynx. You can see the vocal folds, thyroid cartilage, cricoid, all this you can identify. So when you can identify all the cricoid and the thyroid cartilages, you should be immediately, also identify the gland that is around it, that is the thyroid gland. This is thyroid gland, and it has two capsules. One is the true capsule. Remember thyroid for true, okay? So with the thyroid, you have true. With the parotid, you have superficial and deep. True capsule and false capsule. So true capsule, remember, true capsule is actually the condensation of the tissue of around the gland itself. That is true capsule. False capsule is what is outside, pretracheal fascia. Yes. So here what happens, the fascia is known as pretracheal fascia. Now what is this pretracheal? These are all the modifications of the deep fascia. So like that, you have pretrachea and you have prevertebral, you have investing layer, investing layer you have, and also you have temporal fascia. All these are nothing but the modifications of deep fascia in the head and neck region. The deep fascia is not much modified in the other parts, but in the head and neck region, it has got a lot of modification and many, many different names. Okay, like we have those Hindu gods, so many names, but God is one, it is like that. So deep fascia is like, protecting everything, but it has so many names. So you can see the fascia forms outer false capsule, and that is what Santosh said, pretracheal fascia. And you know what happens? The posterior part of it is very thin, and it is not at all defined, and hence the thyroid swellings grow inferiorly and posteriorly. Because the fascia is not holding them, the thyroid swelling you cannot see anteriorly, but it occupies the space behind it. That is, it grows posteriorly. Okay, so in the X-ray and MRI scans, you can identify the swelling of the thyroid posteriorly. Unless it is goiter or something, you will not see the thyroid gland. If it is infected, you can't see them grown anteriorly. So it may also compress the other structures behind. So behind the thyroid, you know that it is lying against the thyroid cartilage, and you have larynx, and then you have pharynx, esophagus, etc. So when it compresses the esophagus, naturally the food that passes through will have obstruction, and it is called dysphagia. So that is one of the reasons for the patient to see the doctor. Otherwise, you would not know that there is an infection. So this is the modifications of deep fascia. You can see the investing layer, you can see pretracheal layer. So pretracheal is here in front of this is the thyroid gland, and this is the isthmus. I'll put it as I, and you can see this is larynx or trachea. This is the esophagus. So here it can, since it presses on the esophagus, it can really press on the contents of the esophagus. Okay, so now the one which is in blue is prevertebral, and around them like a collar is the investing layer. Investing layer is in red actually. So this is investing. Investing layer encloses two muscles. It encloses two muscles. This is sternocleidomastoid, and here at the back it encloses trapezius. Okay, so it encloses the muscles, two muscles like a collar. And you can also see pretracheal, prevertebral, and you can see the carotid sheath here. That's also modification of the deep fascia. Okay, so this is what happens in the pretracheal applied aspect. Okay, next question. Subhajit, good morning. Blood supply. Now, blood supply of which gland is shown here? Anybody? Anyone has an idea? Give me a second. Blood supply of which gland? Do you identify the gland? What is this? Yes, it is the tonsil. Okay, tonsil has very rich blood supply, and the blood supply is mainly from the external carotid artery branches. What are the branches of external carotid that supply? Pranav, good morning. External carotid artery branches. Now, which one supplies? You have branches coming from the facial artery, and you can see ascending pharyngeal artery branches. Right? That is also giving branches. You have seen so many tonsillar branches coming from the facial artery, and then you can also see the lingual artery giving branches, and also the maxillary artery. So remember these are the 4 important branches of external carotid which give branch to the tonsil. So descending palatine is a branch from the maxillary artery which supplies the upper pole of the palatine. And you can see the dorsal lingual, you can see the facial giving those tonsillar branches, and you can also see ascending pharyngeal also giving some of the twigs to the palatine tonsil. Okay, so this is palatine tonsil blood supply, which is very, very important. These are the, so how do you remember this? Sometimes, we have so many things listed, but we don't know how to recall them when we actually need it. So this is a very easy and a simple mnemonic, that is love, father, and mother. So you'll remember all the 4 branches of external carotid artery. Try this. Try the mnemonic. You also can attend my session at 10 p.m. every day. Every day you have 10 p.m. on YouTube. I give minimum 6 to 7 mnemonics. So if this is what makes you, recall the things, then you should just keep a book and write down the mnemonics. Right now, you may not, see any interest in the mnemonics, but as you, advance to other subjects, you will have high tendency to forget anatomy, because anatomy, once you don't, you stop revising and stop looking at it, everything just goes off your head like that. It is very volatile subject. That's what I want to say. So you want to remember the things, you have to stick on to some method. So mnemonics is something that I always suggest. So I have 6 to 7 mnemonics which I give every day at 10 p.m. I have this nice session on mnemonics. So please attend. Okay. Cynthia, Pranav, Subhajit, I'm telling you all to attend 10 p.m. session on YouTube. Next, there is this tonsillar bed. Any idea what are the structures that form the tonsillar bed? What structures form the tonsillar bed? Again, even this will have a mnemonic. I'll give you the mnemonic provided someone answers the question. What are the structures you can see? And tonsillar bed is nothing but the posterior structures or posterior relations are the tonsillar bed. Anteriorly, you can see that it has those, crypts. They're called crypts. And that face is the tongue. But posteriorly, you have many things that is lined up. But you have to remember that in an order. You can't just remember it like that. You have to remember them in order. And what are the structures? You have pharyngobasilar fascia, superior constrictor muscle. You have styloglossus, buccopharyngeal fascia. These are the things that you can see in the immediate 4 layers as the tonsillar bed. You can just go on endless, but you want to just remember 4 or 5 because that's enough. And beyond that, whatever until the skin, you can go on mentioning as the tonsillar bed, but that is not required. See here, mandible, masseter, everything you can tell, but only 4 or 5 immediate structures related to the posterior aspect. If you remember, it's enough. How do you remember this? Now you have a mnemonic for that. From within outwards, you have PB, SS, BP. So you have pharyngobasilar, superior constrictor muscle of pharynx, styloglossus, buccopharyngeal fascia. So these are the 4 things that you can remember for the posterior relations. Okay, or you can also call this as tonsillar bed. Next, you have one nice interesting picture which is like nicely color coded. What is it? You have various tonsils. This is called Waldeyer's ring. Waldeyer's lymphatic ring. Now, what are the tonsil or the lymphatic aggregations that form the tonsillar Waldeyer's lymphatic ring? What forms the lymphatic ring? Let's see. There is pharyngeal tonsil. Just look at the picture. What are the there is pharyngeal tonsil that is present on the roof of the nasal septum. And then you can see there is tubal tonsil just above in the nasal cavity itself. These 2 are in the nasal cavity. Okay, these 2 are in the nasal cavity. And then you have the palatine tonsil and the lingual tonsil. These 2 are in the oral cavity. So tubal tonsil, pharyngeal tonsil in the nasal cavity. You have palatine tonsil, lingual tonsil in the oral cavity. And this is what, forms a nice ring that guards the entry into the mouth. And this is called Waldeyer's lymphatic ring. So let's see what is its use and what are the tonsils. Now you know that palatine tonsil, lingual. The tubal tonsils are also, present within the fossa that is called fossa of Rosenmuller. And there are a group of lymph nodes by the same name, Rosenmuller lymph nodes. And lateral pharyngeal bands, nodules, all these are some of the things that are forming a ring around the oral cavity, and that's called Waldeyer's ring. Next one. Identify this. How do you identify this? What is this? This gives you a nice, picture of one leg completely all right. The other one is dropped, right? You can see that it is dropped. Why do you think it is dropped? It is pointing downwards. There is nerve supply that you need to remember. So whenever there is a muscle that is not functional, or it is not efficient, or it is thinned out and wasting, then you should remember that it is due to the nerve supply. So nerve supply, you have the sciatic nerve which divides into tibial and common peroneal. Common peroneal again divides into two. One is superficial, another one is deep. Superficial and deep. So superficial one supplies the lateral compartment, deep one goes anteriorly. So here you can see common peroneal, and it is very much related to the neck of the femur. So this is neck of the fibula. And it divides into two. There is one which is going in front, that is called the deep, and the other one lies on the lateral aspect, that is called superficial. So when it goes, one goes laterally, another one is going in front, that is deep, you can see that the one which goes laterally supplies the peroneal muscles. It supplies the peroneal muscles. And the one which is in front, and that supplies the dorsal compartment or the anterior compartment. Anterior one is also called the dorsal compartment. And here you can see the neck of the fibula is fractured. When such a thing happens, because it is very superficial, when such a thing happens, always there is a danger of injury to the common peroneal nerve. The common peroneal nerve, when it is damaged, it can result in, cut off of the nerve supply to the anterior compartment and lateral compartment. Now, if I have to take another slide, anterior compartment and lateral compartment, you have peroneal muscles in the lateral compartment, and anterior compartment you have dorsal or extensors. And what do they do? Extensors do dorsiflexion. And what do lateral compartment do? They do plantar flexion. Okay, they do the plantar flexion. So when such a thing happens, dorsiflexion is not happening because of the damage to anterior compartment. That in turn, you have the damage to deep branch of common peroneal, superficial branch of common peroneal. So plantar flexion will not happen, and here dorsiflexion will not happen, and that results in condition called the foot drop. Okay, so this is what you must remember. Next, the most common cause of foot drop is peroneal nerve injury, and you should always remember near the neck it is, neck of fibula. That is where it gets injured. Okay, if it has to. So usually during the lathi charge, when the policeman hit the, just to, disperse the gathering, they could hit with the lathi, and that always is one of the reasons for the injury to common peroneal nerve. They would get hit on the lateral side of the leg, and that can damage the common peroneal nerve. So it supplies the movement of the muscles in the extensor compartment as well as the lateral compartment, and that's why extensors, since they don't work after that condition, it results in the drop of the foot pointing downwards, and that's what you saw in the picture also. Okay, there is one thing from the neuro. Let's see what is this neuro. What is this neuro question all about? You have optic nerve, you can see the fibers exit the sclera and they're all covered with glial cells. Okay, the fibers exit the sclera and they are covered with the glial cells, and that is optic nerve. And you can see this optic nerve, optic nerve and the ophthalmic artery, they pass through the optic canal, and you can see the optic canal ends here in just in front of the lesser wing of the sphenoid, and then there is a crisscross of the fibers, and that is known as optic chiasma. So here optic chiasma is the second step, and then it forms the tract. So optic radiations are there. So optic tract is formed, and then they, rest in the lateral geniculate body. They reach the lateral geniculate body, and through the lateral lemniscus, they reach the optic radiation. So you remember that optic radiations, and then you can see there is this last stretch that is called the visual cortex. Visual cortex is the number 18 and 19 in the occipital lobe. So for visual pathway, the important thing that you should notice always is the lateral geniculate body. So remember this, it is always asked, lateral geniculate body is associated with visual pathway or the auditory pathway. Auditory pathway has, auditory pathway has medial geniculate body. And also remember lateral lemniscus. Okay, these two are associated with the auditory pathway. Lateral geniculate body is associated with the visual pathway. Next, now there is a condition, this is optic nerve. So now optic nerve multiple sclerosis, it commonly doesn't affect other nerves of the peripheral nervous system except for this optic nerve. Why? So this is, again, it is more vulnerable to the effects of demyelinating diseases. Okay, optic nerve. Why it is so? Optic nerve is more vulnerable. Why it is so? So this is one question you can think of. Now, optic nerve, where the unmyelinated axons of the retinal ganglion cells, they pierce the sclera, first of all, and then it passes into the orbit, and you know that they exit the optic canal and they enter the middle cranial fossa, where I told you just in front of the lesser wing of the sphenoid, they form a crisscross called the optic chiasma. So now here what happens, the fibers from the medial nasal half of the retina join the fibers of the lateral half and they form the chiasma. Then they form the optic tract. So here most of the fibers from the optic tract, they terminate in the lateral geniculate body itself. Okay, and from where the axons are relayed to visual corticals in the occipital lobe of the brain. Now here, myelin sheath that surrounds the sensory fibers, they are from the point at which they penetrate the sclera formed of glial cells rather than the neurolemma. So they are not formed of neurolemma, but they are formed of glial cells. Okay, so this is not a sufficient, covering. So that is the reason they are more vulnerable to the demyelinating diseases such as multiple sclerosis, and that demyelinating disease doesn't affect other peripheral nervous system because they are all covered by the covering of the Schwann cells, that is neurolemma. Okay, so they have this covering, and this optic nerve has the covering made of glial cells. That is the reason it is more vulnerable. So this is one important reason. I wanted to just give it in detail. That's why I just put up everything. Okay, so this is another slide where you can see different layers of the scalp. Okay, this is a scalp picture where you can see SCALP. Now you can see the first one, that is the skin. Then you can see C, that is the connective tissue. This is number 2. This is the first one. And then you can see A, that is Gallio-aponeurotica, that is 3. And then L is loose areolar tissue, that is the 4th one. This is the 4th one. This is the 4th one. And the last one is pericranium. This is the 5th one. So there are 5 different layers. The loose areolar tissue actually acts like a filler. So you can see the pericranium is the outer covering or the outer, there are two compact bones, and then there is this inside, there is the spongy bone. So this outer one is covered by the pericranium, and the inner one, you can see that it is covered by the first layer of the dura mater itself. So now here you can see this is the 5 layers, and the first one is usually very prone to cyst, and that is what is shown in the picture here, that is the formation of the sebaceous cyst. Okay, this is neatly shown. It is calcified as well. That's why it is seen in the X-ray like this, and MRI scans also you can identify. And this is calcified sebaceous cyst. Okay, next one, black eye. What is black eye? Now I mentioned all the 5 layers of the scalp. Now the first layer is skin, second one is connective tissue, dense connective tissue, second one, and the third one is aponeurosis, loose areolar tissue, P is pericranium. Okay, so you have 5 of them together. Now, what is black eye? Where is it, related to? Which part of the scalp is related to? So black eye is actually because of the blow to the skull. So now it could be trauma, it could be the blow on the face, the collection of the blood collection around the orbit is what makes it look like black, like raccoon eye. So this is the collection of blood in the subaponeurotic space. So it produces generalized swelling, and the whole dome of the skull, gets affected. So you can see that the eyelids are also swollen and bloodshed, and blood slowly gravitates into the eyelids because the frontalis muscle, which occupies the forehead region, does not have any bony attachment. So because of this, it also gravitates into the eyelids and turns this area around the eye into a bloodshed eye, and that's called black eye. This is very important, thing, and this is related to the 4th layer, that is loose areolar tissue. Because which vessels are involved, we should know. The 4th layer has emissary veins, and emissary veins are the ones which break open and lead to the seeping of the blood in and around the subaponeurotic space. Next, similarly, in the same region, you also have the pterygoid plexus of veins, right? Pterygoid plexus of veins does the venous drainage, and communications it has with the orbit in front. You can see it also has communication with the cavernous sinus above, and it also has communication with the face in front. So orbit, cavernous sinus, and face. So these are the 3 regions from where the infection could be carried. Now, from the orbit and the face, the infection can always reach the cavernous sinus in a retrograde fashion. So now, many veins of the head contain absolutely no valve and are very potential route for infection spread. So you can see that. And venous drainage, if you have to look at the clinical notes, you can see the anastomosis of the pterygoid plexus of veins within the facial vein and cavernous sinus. It will represent an important potential pathway for the spread of infection. That is one thing. Then normally blood from the medial angle of the eye, nose, lips area, they drain through the facial vein. And veins in the head, including those of the pterygoid plexus of veins, they do not have valves, but the infection may therefore reverse the flow and into the cavernous sinus and resulting in ultimately meningeal infections and also the thrombosis of cavernous sinus. Next one, ulcer on the lip. Now, ulcer on the lip, you can see that the ulcers usually are present on the lips, and you should see which artery will, hemorrhage whenever there is an ulcer on the lip, whenever there is an infection and there is a break open of this ulcer, which artery do you think will hemorrhage? Now you can see anterior ethmoid artery also supplies this region, and there are branches from the greater palatine artery, and you can see posterior ethmoid artery. There is anterior and posterior ethmoid, both of them are from the internal carotid arteries. And these are the branches from this is from the facial, and this is from the maxillary. And which forms, nice anastomosis around the tip of the nose, and that is called Little's area. This upper lip area is also supplied by this facial. So you can see the Little's area, epistaxis area. This is the one, and the all these, you can see that they anastomose, and you can see the branches as well. Internal carotid gives this ophthalmic, which has anterior and posterior as the branches, and then there is the facial is given by the external carotid, maxillary also by the external carotid. How they give this greater palatine branch, and greater palatine forms anastomosis here. The branches of spinopalatine also forms anastomosis here, and you can also see facial artery. It forms superior labial and septal branches, and that also forms the anastomosis. So anastomosis is formed within all these branches. Okay, so the one which supplies the upper lip area would be a branch from the anterior ethmoidal artery. So this is what, hemorrhages whenever there is an ulceration. Okay, this is the list of nice things that we discussed today. So we have discussed a lot of head and neck regions. In the future, we will also be including a lot of MCQs from the neuroanatomy sections and embryology as well. And I have some important note that I would like to mention it here. I have classes running every single morning at 8 a.m. So 8 a.m. classes are for MCQs, and there are classes at 10 p.m. and this is the YouTube class, and this is given more importance to mnemonic based questions. Okay, mnemonics is what we discuss, and we discuss the questions thoroughly so that you have understood along with the mnemonic how to implement the mnemonic. Everything comes at one hand. So this is 10 p.m. class, and then I also have some plus classes running at the same time. So I have classes right now running for the first year professionals. And there is also class vertical integration. Okay, this is with the radiology and ortho department. So ortho and radiology, I'm going to, you know, you know, club with anatomy separately on different dates, and then we are going to go with some nice topics. We are going to discuss few topics. We are also going to do some MCQs related to the same. So do join in for all this, and this is going to be in the end of this month. So this part is going to be end of this month, and then we have a 10 p.m. class, and that is every single day, YouTube, and 8 a.m. class is with the MCQs and some interesting topics. So Dr. Varsha, Tania Banerjee, Shruti, Cynthia, Pranav, all of you join in and make this 10 p.m. class a very interesting one by your interactive messages. All right. So this one I'm going to end at this, and do join in every day at 8 a.m. and that would be a interesting class with MCQs. Thank you so much for joining. You all have a good day. Bye.